Good evening. On behalf of Sutter Health, welcome to our Ask the Expert series on neck and back pain treatment. If you're hurting, you've come to the right place. Tonight, you're going to learn about what causes neck and back pain, along with some of the latest treatment options with Dr. Katsuura. We're really grateful for the Zoom webinar platform and just a couple of housekeeping items on how an online webinar works. We can't actually see or hear you, so when you have a question for the doctor, anytime during the presentation, scroll your mouse or pointer over the Q&A button. It's somewhere right around there. Click Ask a Question and type it in. Dr. Katsuura will answer your questions at the end of his presentation. And once the webinar is completely over, a referral form and survey form will pop up in your browser, and it'll have a section for you to ask additional questions, give us some feedback about tonight's session, and an option to schedule a consultation if you're interested. And in case you don't see the form pop up tonight, don't worry, we're going to send it to everybody by email tomorrow. So sit back and let's get on with the presentation. With us tonight, Dr. Katsuura is a board-certified orthopedic surgeon specializing in complex spine care. He believes in using surgery only when necessary and maximizing the use of the latest surgical techniques. Dr. Katsuura received his undergraduate degree from the University of California at Berkeley, attended medical school at the Royal College of Surgeons in Ireland, completed an orthopedic surgery residency at the University of Tennessee College of Medicine, and he fulfilled a fellowship in spine surgery at Cornell's Hospital for Surgery in New York, New York. He's the author of the Spine Encyclopedia, a book about caring for your neck and back. But most importantly, Dr. Katsuura has outstanding treatment outcomes. His patients consistently give him top ratings in resolving their pain, and he's a nice guy. So despite a very busy schedule, we're grateful he could make it here tonight. So with that, please welcome Dr. Katsuura.
Thank you so much, Sean, for that awesome introduction. And thanks everyone for joining me tonight. I'm really excited to be giving this talk about neck and back pain. And hopefully we'll be able to learn some stuff, cover your guys' questions, and demystify some of the scariness around orthopedic spine issues. And so the title of my talk is The Bad Guys. Since this is Halloween and everyone's getting ready, we're going to talk about the evil cast of characters that are really hell-bent in taking not only your spine down, but you down, and what we can do about it. So Sean gave a great introduction, and I'll just add a little bit more about my practice. Currently, I'm in private practice, and I work out of Novato. I grew up in Berkeley, just across the bay. And I do have a website, katsuuramd.com, and there's loads of clinical information on the website that you can access. I have Instagram and YouTube, where I post very frequently nowadays about issues revolving about low back and spine and other issues going on in the clinic and in the world. So that might be of interest to you if you're interested in learning more at the end of this talk. So let's break the ice with a little demo here. This is a picture of a person whose spine is functioning optimally. And then you can see that they've just finished a long hike into the mountains. They are looking around with their neck, observing the majesty of nature. They're carrying an extremely heavy pack effortlessly, balancing on a rock kind of precariously. And really, all of this is happening because of their back. But what's interesting is this person probably doesn't even realize that their back is doing anything for them at this time. The back is a very passive structure, and it allows you to lead this upright life that we all take for granted until things go wrong. And it's incredibly durable, incredibly strong, and versatile. It can handle a lot, as you can see in this picture, but ultimately it is a machine and it can break down. So in contrast, I would guarantee you that the person on the right-hand side realizes that they have a spine and a back every single day. They have some spinal deformity here. Obviously, ambulation has become more of an issue. They're requiring a walker to get around. Maybe the muscles aren't working as well as they used to. And they have a poor posture with their neck and likely having pain on a daily basis because the back has stopped becoming this, stopped acting as this very versatile machine and is starting to wear down and cause problems. And the reason that it starts to cause problems is because these bad characters start to come out, and they really are nasty little guys. And they have names like disc degeneration, osteoporosis, myelopathy, spondylolistheis, radiculopathy, and then their king is stenosis. And so these are the guys that come out. And to me, they really do feel like this evil cast of characters because they come and visit my clinic every week. I know exactly what they look like. I know how they present. I know everything about these guys. And they really are these evil little dudes that come out of the woodwork into your life to ruin it. But the good news is that we have treatments for almost all of these things that work exceptionally well. And this isn't a diagnosis of cancer or some ailment that does not have a cure. These all can be cured with modern medicine. And that's something that I'm very passionate and excited about. So the outline tonight, we're going to again talk a little bit more about some basics, talk about the spine, how it works, why it matters. We're going to get into the nitty gritty about these bad guys that come out of the woodwork. And then we're going to talk about solutions that are available. Just a little disclaimer about this talk. I always focus on the individual when they come and see me in the clinic. The spine is incredibly complicated and every treatment is nuanced. And so even though I'm going to be speaking in general terms tonight, some of these things may or may not apply to the conditions that you have. And it really requires years of training, years of practice, and a good amount of expertise to make a clinical diagnosis and clinical treatments. So always check with your doctor before pursuing any treatment options. So let's talk about the spine and why it matters. So in a normal spine, it connects your shoulders to your lower extremities, and that allows you to do things like carry weights, transfer weights in different directions. You can even bend down and pick things up because of your spine. You may not realize it, but the spine is the thing that allows you to do that and do all this in a coordinated fashion. You can look over your shoulder because your neck has so much rotation. It's really incredible. And it also allows for normal neurologic function. The spine is the armor, the casing that protects your central nervous system. And as you may or may not know, the central nervous system is important for things like balance, sensation, motor control, going to the bathroom, and sex. These are, I would assume, very important for most people. This is what a normal spine looks like. This is a little sketch, and this is your spine in all its majesty. There is a cervical spine, which is the first 7 vertebrae. Oh, sorry. And then in the middle part, or the mid-back of the spine, is called the thoracic spine. And then the lowest 5 vertebrae are called the lumbar spine. And we refer to these vertebrae as C for cervical, T for thoracic, and L for lumbar. So if I say L1, I'm usually talking about the first lumbar vertebra, or T12 is the 12th thoracic vertebra, etc. And you can see that it has this beautiful curve to it. And these curves are what allow you to stand upright and in a balanced posture, which I will explain. This is what's called the segmental unit. The spine is basically a series of links or chains, and every vertebrae is connected by an intervertebral disc, which is a gel-like spongy structure. And there are a number of bony prominences on the spine that stick out that allow for muscular attachment. And so the segmental unit basically consists of a vertebrae or 2 vertebrae connected by a disc. And we will be referring to this later in the talk, so make a mental note of that now. And this is the cartoon that I'm going to be using to describe the segmental unit of the spine. You can see the dark blue structures are the vertebrae and the light blue is the intervertebral disc. And I'm going to use that as a cartoon to illustrate some of the problems that can occur in the spine. So again, the spine is really important for upright posture. And if your spine is working perfectly, you don't expend any energy to stand upright. All your muscles are perfectly balanced and relaxed. And it's really incredible that your body can do this. But when things start to go wrong, it becomes more difficult and the muscles actually start activating at that point, which can be problematic. And obviously, the spine is important for a lot of dynamic motion, like swinging a tennis racket or golf club. It requires tremendous coordination and power, all of which is transmitted through your spine. And I just have this slide in here to illustrate how important your back is. So the person on the left has an above knee amputation, meaning that they do not have a leg on the right-hand side. But you can see that they're living their life out. They're on a beach somewhere, traveling, doing what they want to do, and they're missing their entire leg. But in this situation, life can go on with a prosthesis. But there are no prostheses for your back. Your back is incredibly important. And if it goes out, it will remind you every single day that something is wrong and really can take over. And I see it all the time in my clinic. So on that note, let's start to talk about what goes wrong with the spine. And the first evil character that we have tonight is disc degeneration, which really leads into many of the other problems, as we will see. So what happens as we get older, and what you can see here in this illustration on my right, is that the discs start out very well hydrated, they're plump, they're very absorptive structures, they can bounce, they're springy, but as you start to get older, they lose that hydration, they start to become dry, cracked, desiccated, ultimately they wear down, they break apart, and the bones get into contact with one another. And that's when arthritis sets in and things start to go wrong. So as you get progressive destruction of the disc starts to form bone spurs, they become collapsed, the bones get closer together, and even deformity and slippage of the vertebrae can occur. What happens to your overall posture as disc degeneration occurs is that you start to lean forward, just like the lady in the elderly lady in the slide I showed before with the walker. She's pitched forward because the discs are likely degenerated, have collapsed, and that allows the vertebrae to shift forward, and that's what's called loss of lordosis, or loss of the lumbar curvature. It's incredibly painful when it happens. And you start to straighten out like this. So when you have disc degeneration, that can result in low back pain, and it can result in this changed posture, both of which can be incredibly painful. And we're going to get into more on how we treat this a little bit later, but it's important to note that disc degeneration is the root of many spine problems. It happens to everybody. In some people, it will be asymptomatic. In some people, it will cause problems, particularly if there is compression of a nerve. And it can result in more serious problems like deformity and stenosis, which we'll talk about next. So the next evil character is called stenosis. And stenosis is just a term that we use in medicine for narrowing of a structure. If you had a clogged pipe at home and you asked a doctor to describe it, he would say, oh, you have stenosis of the pipe. It's just a term that we use. So how does it apply to the spine? Well, in the spine, like I referred to earlier, you have a spinal canal, and that is the contents of the central nervous system. So either the spinal cord and or nerves run through the spinal canal. And so you can see here the little vertical structures, those are just the nerves running through the spinal canal, and they have no problems right here. You have a nice disc and there's no compression, the nerves are happy. But when you start to get disc degeneration, things can go wrong here. One is that it creates a laxity between the vertebrae, and that forces your body to try to respond and stabilize it. And it does so by generating more tissue in and around the spine. And so over time, this tissue can accumulate, and it can accumulate inside of the spinal canal. And that is what's called stenosis. Once the spinal canal diameter reaches a certain point, it crushes the nerves with every move you make. So if you get out of bed, the nerves are getting twisted and pinched. If you walk, the nerves get kinked off, and that can be extremely painful. So how does this present? How does stenosis manifest itself? Well, it can cause low back pain, just like degenerative disc disease can. It can cause a change in your posture because you're trying to make up space in the spinal canal. You're trying to accommodate for that, and shifting your posture into a forward flex posture can sometimes alleviate that pain. So you may find yourself walking around in a hunched forward posture if you have spinal stenosis. And then the pain can travel down the legs. Once the nerves get pinched, obviously the nerves live in the spine, but they exit and they travel down into the legs, and then from the neck, they travel into your arms. And that can cause pain, knife-like pain that shoots down your legs. You might have heard the term sciatica before. What that basically means is pain that's traveling down the sciatic nerve, which is the largest nerve in your leg. Sometimes this can get even more serious and result in numbness. Once the nerves get pinched off to a certain degree, they stop transmitting sensory information. And when you start to have numbness and or weakness, we call that radiculopathy. And that just referring to pinching off of the nerves with pain, numbness, and weakness. So it really can be quite a debilitating condition. So spinal stenosis is very common. It's very common as you get older, and it's one of the most common causes for spine surgery in patients older than 65. It's one of the most usual suspects in my clinic. Again, it's very common throughout patients who are older than 65. Almost half of patients have some form of anatomic stenosis. It may or may not be symptomatic. Treatment for stenosis, we start with conservative, things like physical therapy, but stenosis is really a mechanical problem. And patients often ask, will physical therapy cure this problem? It may help. It's usually not going to hurt you. And sometimes it can help condition your muscles and you can regain some function that way, but it will not eliminate the clog in the pipe. After physical therapy, we may try to use epidural steroid injections or ESIs, and these can be beneficial and useful from a clinical standpoint. We inject steroids and numbing medicine into the spine, and they can be really helpful in localizing where your pain is coming from. So I use them to help plan surgery in a lot of cases, especially if there's multiple areas in the spine that show up on an MRI as being abnormal. This can help perform target surgery, but it's not very useful as a long-term treatment for stenosis, and that's been borne out in multiple randomized controlled trials. And the reason for that, again, is this is a mechanical problem. It's not an issue that medicine is going to solve. So what is the treatment? It usually ends up being surgical once it becomes symptomatic for a period of time. Now, I put this little icon in here to remind me to tell you that if you're a little bit squeamish, you don't like seeing blood, I am going to show some images from surgery. So just look away for the next 2 slides, and then we'll get back to some stuff. But I wanted to show this as a very powerful example of what spinal stenosis actually looks like. So here you can see an image of the spinal cord. And if you can see in this area, there's this huge rock, and this is a bone spur that's indenting into the spine. And sorry, I'll just go back to that. And you can see how it's kinking and pinching it off here. And just imagine having this marble of stone in your back, compressing all the nerves as they run down your spine. It's extremely painful situation. And I think this is just a really good illustration of what that looks like from my perspective. And then this is how we take care of it. We just scoop that stuff right out of there, and you can see this big lob of gunk coming out. It immediately relieves the pain, relieves the stenosis, and it can be very therapeutic for patients. And the results of spinal decompression are very good. This has been studied for long periods of time. There are many randomized controlled trials looking at the long-term benefits of surgical decompression for stenosis. And they're very good, especially when compared to non-operative treatments like physical therapy or epidurals, and can really give you your life back. And it not only can relieve the leg pain and pinching off the nerves, but can actually help relieve a lot of your back pain as well. So in summary about stenosis, that was a little bit of a whirlwind, but it's a very common problem. It's probably the most common thing that I see in my clinic. We usually start with conservative care because surgery is not for everybody. We start with epidural injections and physical therapy. Other things that we may try are acupuncture, exercise, that sort of thing. But ultimately, we look to surgery because this is a mechanical problem. This is a structural problem. Medicines, exercise will not eliminate this, will not cure it. And surgery, luckily, has excellent results. Okay, so the next evil character is called cervical myelopathy. And cervical myelopathy is a dangerous condition, and I really wanted to highlight it in this talk because it will sneak up on a lot of people without them knowing. What is cervical myelopathy? Cervical myelopathy, in essence, is stenosis of the cervical spine. So you have narrowing of the cervical spine. Now, this is an MRI cross-sectional image where you can see up at the top here is the brain, and this noodle-like structure is the spinal cord. And you can see these indentations, how the spinal cord is just getting crushed through this segment. And your cervical spine has a lot of motion. You can move your neck around with a huge degree of freedom. And so you can imagine that every time you move your neck, your spinal cord is getting pinched and crushed. And the spinal cord, you may or may not know, is a very eloquent structure. It carries information to and from your brain to your body. If you do not have a spinal cord, you cease to walk around. You cease to have normal neurologic function. So we take cervical myelopathy very seriously in the spine surgery world because there's no spinal cord transplant. Once these neurons start to go down, once you start to have issues with them, they usually are gone permanently. And so we want to get a good hold of the situation before that happens. So if you do have cervical stenosis, how does it present? What are the symptoms? And what's very common I found is a lot of people just think, I'm getting old. Oh, I'm starting to not be able to do the things I used to do. I must be getting old, because cervical myelopathy can be a painless condition. It can be associated with pain. You can have neck pain, but in a lot of instances, it can be painless. You just start to have neurologic issues. You can have pain that shoots down your arms. That would be radiculopathy, so having pinching of the nerves. But in a lot of cases, you may just have numbness, worsening numbness of the hands and arms. You can become clumsy in the hands, so writing out your name, putting a key into the door, picking up small objects like buttons, that can become difficult for you. And you can start to lose your balance. Just walking a small distance become difficult for you. Walking in a dark room can become difficult for you so if you have no feedback from light, that can be very difficult, and your gait can be totally wobbly once you start to have this. So not everybody with stenosis of the cervical spine has cervical myelopathy. So the term cervical myelopathy really refers to the clinical syndrome that I just described. So the clumsiness, the wobbliness, the numbness, maybe pain, maybe arm pain. But you can have stenosis and not have that condition. But usually once you have stenosis, you're headed in that direction, especially with enough time. So not everyone with cervical stenosis needs immediate surgery, but over the course of 4 years, about 25% or 1/4 of people will start to develop this syndrome. And once you start to develop this syndrome, the horse is kind of out of the gate. You're already starting to have neurologic damage at that point. That's why we take it so seriously. And we also have excellent minimally invasive treatment options to deal with this. So I love the procedure, this is called a cervical laminoplasty. And what you can see here is a patient who had the multi-level kind of indentations in the cervical spine, pinching off the spinal cord. And I think a lot of surgeons would treat this with a so-called fusion surgery, where they stop the neck from moving and prevent motion, and that can be a really debilitating surgery to get through. But a cervical laminoplasty is a motion preserving procedure that allows you to keep your neck motion, and if done properly can basically allow your neck to go back to normal. We unclog the pipe, we insert these little plates to open up the spinal canal and hold it in an open position, and then everything heals back. And this is an excellent treatment for cervical myelopathy. And these treatments have been studied extensively, just like in the lumbar spine. Surgical intervention for cervical myelopathy leads to significant improvement in neurologic function compared to non-operative treatment. So again, a lot of patients will ask me, well, can I treat this with physical therapy? Can we do exercises to manage this? And the answer is usually no, because once you have that pincer lesion on your spinal cord, every time you move, you're imagine crushing like this jelly, very delicate jelly spinal cord, and it's undergoing progressive damage at that point. So exercise is not going to cure that problem. Time will not reverse the aging that goes on here. You really need to have a targeted intervention, get the pressure off, and then just go back to your normal life after that. So in summary, myelopathy needs to be taken seriously. If you start to develop any of those symptoms, it needs to be evaluated, and time is usually of the essence. So the sooner you get it treated, the better your outcomes will be. It's commonly missed and it's commonly misdiagnosed, and patients think they're just getting old. Again, it can be a painless condition. So you're not driven to the doctor to do something. If you have pain in your back or severe sciatica, you're usually going to seek out medical care. But if things are just gradually, slowly getting worse in your motor function, you may not notice it until a lot of time has passed. And so that's why a lot of people just think they're getting old. It's usually, that may be the case that they are aging, but that does not in and of itself cause these issues. And there are really, really great treatments for treating cervical myelopathy, and they have excellent outcomes, and they've been studied now for a long time. So there's lots of options here. Okay, the next character on the list is osteoporosis, and with osteoporosis comes compression fractures. So let's jump right in and figure out what osteoporosis is. I'm sure a lot of you have heard about it. Osteoporosis basically just means that over time, everyone's bones start to degrade. Your bones are probably as strong as they're going to be in your late 20s to 30s. And unfortunately, after that point, you slowly undergo this slow progressive decline where your bones gradually become weaker and weaker. And the struts inside the bone become a little bit more brittle. And that can lead to weakening of the bones. So just between those two slides, you can see how the bone gets a little bit thin, more transparent. On an x-ray, they don't show up as brightly as they would normally. And then over time, they can weaken and actually have compression fractures. And what happens when you have a compression fracture? Most of the time, it prevents with severe back pain. And actually, if you have wedge compression fractures, then you can start to have deformity of the spine. So that's when you start to have this postural abnormality that can't be corrected with just thinking about it. You can try to straighten your back, but your back won't straighten anymore because it's undergone this permanent deformation. And these can be extremely painful. Osteoporotic compression fractures can be debilitating. They can send you to the emergency room. They can really interfere with your quality of life, your ambulation, and just doing your activities of daily living. Unfortunately, osteoporotic compression fractures are happening worldwide on a very high rate. So even in the span of the time that I've been speaking to you guys, hundreds of osteoporotic compression fractures have probably happened in the United States, and thousands have happened throughout the world. It's very common. It's more common in women than in men, but men can still be affected by them. Women, when they undergo menopause, have accelerated osteoporosis at that stage and are affected by compression fractures, typically in their 50s, 60s. And that rate only gets worse as they get into their 80s. Men are usually about a decade behind women in developing osteoporotic compression fractures, but it affects men just as well. Sometimes compression fractures can be asymptomatic. If they're small and if they heal quickly, then usually people just have mild pain and they can get better. But if they're severe, they can become incapacitating and really take over your life. And osteoporotic compression fractures, we have great treatments for them now that are minimally invasive. They're usually outpatient surgeries. So if someone comes in, they can be treated for the compression fractures surgically on an outpatient basis and get back to their life. And we use this procedure, which I'm going to show here, called the kyphoplasty. And what you can see here is I'm inserting a small needle into the spine. That's just like getting a flu shot. And through this needle, I'm able to put some cement into the bone, which basically stabilizes the fracture and takes away the pain and prevents further collapse of the vertebrae. And so that's one thing I didn't mention, is that once you have this fracture and it starts, it can keep going until your vertebrae gets totally pancaked, depending on how bad your osteoporosis is. So this can stabilize your back and really offer a tremendous amount of relief. And it can be done on an outpatient basis, and all you get is a Band-Aid at the end. So patients generally really like this procedure. Nowadays, we have even more powerful ways of treating osteoporotic compression fractures. So you can see here's the fracture here, and it's crushed down, and you can see that the spine is kinked now, it's angulated. And we are sometimes able to insert these small devices that act as car jacks almost to expand the vertebrae. And you can see now that the spine is unkinked, it's back into a nice, stable, straight position. And this is a very, very powerful treatment that we can offer. And again, you get 2 Band-Aids for this instead of 1 Band-Aid, and it's outpatient, minimally invasive. So it's a great option for patients. And this has been studied in massive randomized control trials nationwide, and international-based randomized control trials have shown that the kyphoplasty, vertebroplasty procedures are very effective in taking away pain from compression fractures. Not only is it effective for taking away pain, but it can actually increase your survival long-term. Why is that? There's probably a lot of reasons, not just the fact that you have less pain, but you can be more active, more mobile. You're not just on bed rest, letting your body decay and atrophy at a rapid rate. So it's something that I'm passionate about. Just to summarize what we talked about, I know we covered a lot about osteoporosis. So let's just slow down for a second and summarize the main concepts. So osteoporosis is going to affect everybody. It's just a matter of time. Everyone gets it at a certain point. Once your bones reach a threshold of weakness, they get very prone to fracturing. And so you don't have to be in an accident. You don't have to trip and fall. You could sneeze hard and your bones could be brittle and you could suffer from a compression fracture. We'd like to use kyphoplasty early. The earlier we get to it, the better results that it has. And also it prevents future collapse of the vertebrae or develop the vertebrae turning into this pancake. And once you get to that stage, kyphoplasty is not very effective. So we try to do these as early as possible. All right, so the last evil dude that I want to talk about tonight is spinal deformity, and one facet of that is a term called spondylolisthesis. And I'll explain, that's a complicated medical term, and I'll explain what it means, but it basically just means that you have a slip disc in your back. So let's dive right into that. Here we have our spinal segmental unit, the disc and 2 vertebrae, and we'll put the spinal canal in there, I'll put the nerves in there, and then we start to undergo some disc degeneration, and that creates laxity in the spine. And it should be a taut connection between these 2 vertebrae, but when you get the disc degeneration, things collapse, and that allows slippage to occur. And the slippage is what we call spondylolisthesis. Spondylolisthesis can also result in stenosis. So you can see here when the vertebrae slips forward, it kinks off the spinal canal, and this is a very, very, very painful, debilitating condition. So you can, when the vertebrae slips forward, that's called spondylolisthesis, but it can also slip in a lateral fashion. And when it does that, it creates an angled curvature of the spine, and that's called scoliosis, which I'm sure many people have heard about. So spinal deformity can result in everything and above that we've talked about: back pain, leg pain, radiculopathy, numbness of the legs, weakness of the legs. It really is probably the most severe manifestation of spinal disease and can cause all of these problems at once, and it can be very debilitating. Some more bad news is that just like osteoporosis, most people are going to develop some kind of spinal deformity as they get older. The prevalence of scoliosis, degenerative spinal deformity, is about 70% in patients older than 65. Doesn't mean that they're all symptomatic, but this is a very common thing to find on x-ray. If you were to x-ray 1,000 normal people, most of them would have some form of this at a certain age. Just like spinal stenosis, we treat these initially conservatively. We try PT, injections, acupuncture, exercise, pain medications. But ultimately, as you can see from this x-ray, there's no medication that's going to alleviate this. This is a structural problem. And the way I describe it to patients is that if you had a general contractor come to your house and the house was, say, tilted and everything was rolling to one side of the house, and you ask the general contractor, well, can you put a new coat of paint on the floor? Can you put some more paint on the outside? They probably would say no, because if you have a problem in the foundation of the house, like that's what you need to deal with. And the same thing, unfortunately, is true in spine surgery. But again, we've become very good at dealing with these problems, and the technology that we use to reconstruct the spine now are excellent. And so we can really get great outcomes from doing spinal reconstruction. And this is a little case that illustrates a spondylolisthesis. You can see that this vertebrae is shifted forward on this one. And in this case, I elected to treat this patient with what's called a spinal fusion. So I inserted spinal hardware, including screws and a cage, to recreate the disc, as it were. And I can lock these together, and you can see now I've recreated a beautiful spinal alignment here. And then this patient's going to do extremely well. Here, this is a very painful, lax situation where every time they move, it's going to be causing pain because there's this slip and there's also this laxity between the vertebrae. But once they're locked back in place, they get their normal spinal alignment back. You do lose a little bit of motion through the spine here, but it's not very noticeable to these patients because they've already lost a significant amount of motion. And so usually they don't even notice that there's been a change. If anything, they just feel so much better after this procedure. So surgical treatment of spondylolisthesis has also been extensively studied in the literature. We've compared it to non-operative treatments, and it universally does much better once you start to have pain and neurologic deterioration. So in conclusion, all these problems are somewhat related. They all kind of contribute to what I call the triangle of pain, which is spinal degeneration and stenosis, osteoporosis, and deformity. They come in as a pack. They usually are holding hands, like you saw in the beginning of the slide, and they come in and try to take you down. And that may be one thing or the other that's the main source of the problem. But these are all problems of aging, and people are living much longer now and developing more orthopedic issues. And so we see more and more of these things in a spinal clinic. And at this point in the talk, you may be wondering, is this all bad? Is this what I have to look forward to in old age? What about the golden years? And I think that there are ways that you can optimize your back. And we talk a lot about weight loss, leading a healthy diet, and then exercising your back. And I have a lot of resources on my website that you can check out, and a lot of learning resources about how to keep your back healthy. And I think people just don't pay attention to it. It's not like brushing your teeth. Now, from a young age, everyone was told, or at least I hope everyone was told, that you should brush your teeth 2 times a day. But no one was ever told, oh, you got to do some exercise to take care of your back, or there are specific things that you can do to take care of your back and really maximize its longevity. And I wholeheartedly believe that there are things that you can do. And if you go to visit my website, you'll see a lot of instructional videos on exercise and a lot of the same concepts that we talked about tonight re-explained with animations and cartoons. And I think that could be valuable if this is something that you're suffering from. If you're interested in learning even more, I did write this very extensive book called the Spine Encyclopedia that is available on Amazon in ebook and paperback, and explains essentially everything that you could ever hope to learn about your back and how to take care of it. So that can be found online. And then again, my website is katsuramd.com. I'm on Instagram and YouTube and all those things. So I do post frequently, and I try to provide educational material to my patients so they can demystify some of these concepts, and instead of just being worried or being fearful of these problems, develop strategies to either deal with them, treat them if they're going to have surgery, or manage it in some other way. I really think that there's a lot of fear that goes into the spine clinic because everyone's afraid of spine surgery. And yes, you should be. I mean, it's something that you should only undertake if you absolutely need it, but it can also be a lifesaver in many situations. So I'll leave it at that, and I'll hand it back to Sean. Thank you so much for your attention.
Great. Thank Dr. Katsuhira. That's fantastic. Great presentation. It looks like we have 18 questions in the queue. Dr. Katsuhira will stop sharing his screen with a little red button on top.